either directly or indirectly so far, so hopefully this will go relatively quickly. I can't promise that I'll have time to give back to you at the end of the lecture, but maybe we'll see what happens. So we're going to talk about hematuria and proteinuria specifically first. And like I said, we've talked about some aspects of hematuria and proteinuria already, and then we'll talk about acute kidney injury. Everybody ready for the weekend?
Yes. Yes.
Doesn't feel like we just came back from holiday block leave, does it? No. Okay, so for the first part, we're going to correctly analyze and interpret information about the genitourinary system obtained from various SERV studies and urinalysis reports. We're going to talk about criteria for levels of proteinuria, causes of proteinuria, and then how to evaluate it. Now, I know we've talked about people with large muscle mass excreting larger quantities of creatinine as a result of their muscle metabolism. Is it normal for someone of larger muscle mass to have a higher level of protein excretion at baseline?
Yes.
No. No. So there is a normal baseline level of protein excretion, less than 150 milligrams per day. So if you do happen to see protein on a urinary dipstick, that doesn't necessarily mean that you have to panic and say, oh, this person's got a kidney injury or they've got nephrotic syndrome or something like that, because there is a chance that you might see detectable protein. Now, this amount, you notice it's 150 milligrams per day, not 150 milligrams per spot check. So it shouldn't trip the protein box on a dipstick or on a point of care urinalysis, but it might. And we'll talk about what this normal protein excretion is. So as we talked about before, the quantity and type of protein can identify the site. So does anybody remember what I told you was the cutoff earlier for nephrotic syndrome, the minimum amount of protein excreted per day that would make you think that somebody got a nephrotic syndrome? 3.5 grams per day, very good. So obviously that's quite a bit more than 150 milligrams per day. And then again, the type of the protein that's being dumped in the urine is helpful as well in determining what's going on. So proteinuria is an independent sign of potential future badness, right? Higher morbidity and mortality, especially in diabetic patients. And in patients that have intrinsic renal disease that's of a non-diabetic nature, so something like a nephrotic syndrome or IgA nephropathy. So less than 150 milligrams in 24 hours is considered normal. You may have seen the term uromodulin before. When I was going through my initial medical training, the term for this protein was TAM horsefall protein. So if you've ever seen TAM horsefall protein, it's the same thing. And uromodulin, as the name would imply, the protein helps modulate the constituency of urine. So having uromodulin in the urine is normal. It's excreted in the glomerulus, and it helps in sodium transport, and it's also protective against kidney stone formation, because the dissolved ions in the urine will actually bond to uromodulin and decrease the likelihood that they're going to precipitate out and form crystals. So it is actually it's a normal thing to have, and it's a good thing to have. So if you see protein and then you end up doing a more extensive workup and it doesn't pan out to be something significant, then it's probably uromodulin. It is normal to have some baseline albumin excretion per day. If it's greater than 30 milligrams per day, between 30 to 300, the patient's got microalbuminuria, okay? And if it's greater than 300, then it's severe, and that will definitely trip a dipstick, for sure. But I have seen lower numbers than that end up coming back positive on a dipstick. The other thing you need to know about a dipstick is that it detects primarily albumin, but can the protein box on a urine dipstick be tripped by other types of protein? It can. And so if the patient has something else in their urine that has protein in it, say red blood cells, then you might potentially see the protein box get tripped by that as well. The point is you can't tell what you're dealing with just on a urinary dipstick. You just know that there's the presence of protein. Right? And then like we've reviewed already, greater than 3.5 grams per day is the range of nephrotic syndrome. So is microalbuminuria something you need to worry about? Well, we've already said that it's a sign of increased risk of morbidity and mortality in diabetic patients and patients with non-diabetic renal disease. But you can see here that it's associated with cardiovascular mortality, heart failure, stroke, and vascular calcification. So, and that's independent of the other underlying kidney disease process or their level of kidney function. So even if you've got somebody whose kidney function is normal by whatever measure you're using to determine that, creatinine, cystatin C, whatever it is, if they've got microalbuminuria, the risk for all of these conditions is increased. So it is something that you need to be concerned about. So make sure you're paying attention to that when you're seeing patients who have established renal disease or diabetics. So transient proteinuria is not uncommon. This is one of the reasons why you shouldn't, if you're evaluating somebody for proteinuria, you need to make sure that when they do whatever test you're asking them to do, whether it's just a simple urinalysis or if you're asking them to do a 24-hour urine collection, that they try to avoid exercise, because exerting themselves is going to increase the amount of protein excreted in the urine, and that's normal. If they have an acute illness, like the flu, then they may have an increase in protein excretion in the urine. So you want to make sure that you control for confounding factors when you start looking at an evaluation for proteinuria, and know that if you're seeing somebody because they've come in for an acute process like the flu, that you may see protein in the urine. You want to make sure that resolves. Okay. Glomerular and tubular proteinuria is pretty self-explanatory, right? So glomerular proteinuria is caused by glomerular disorders, and tubular proteinuria is caused by tubular disorders, due to faulty reabsorption. Orthostatic proteinuria, it's benign. So if you happen to be in a situation where you're seeing kids and they've got proteinuria, then it's potentially a normal finding. You need to work it up and make sure there's not something else going on, but it's benign, and you can rule it out pretty effectively by doing an overnight supine urinary protein excretion. And then overload proteinuria. So if somebody has an underlying condition like plasma cell myeloma or rhabdo, then the cause of their proteinuria is just that their system is overwhelmed with free protein in the urine, or excuse me, in the blood, serum, and the body's trying to compensate for that, which is also something that should resolve when the underlying problem is addressed. All right, so how do you test for it? Well, we've talked about this quite a bit already. So dipstick testing is going to be your initial screening tool. More often than not, you're going to find it incidentally. Nobody comes in saying, hey, I think I have proteinuria, right? I remember being taught that having exceptionally foamy urine is a sign of proteinuria, but I've never actually seen that pan out in actual application. So take that for what it's worth. Theoretically, having larger quantities of protein in urine is going to change the surface tension of urine, just like soap does, and so you may see more foaming in a urine specimen, but you can't take it to the bank. Like I said before, make sure that they don't do a urinalysis immediately following exercise, because they may have a false positive. It's truly positive, but it's false for being any sort of pathologic process. Who do you think actually has time to do 3 separate urine samples? And I'm not just talking about you as the provider, I'm talking about patients. Do you think they have time to come in and give 3 urine samples? See, practically speaking, it doesn't happen very often. But that's the textbook answer. Now, should you do that if you suspect that somebody has a confounding factor going on behind the scenes, like they recently recovered from the flu? Yeah, it's probably not a bad idea to just do 3 plain urinalyses as opposed to jumping immediately to a 24-hour urine collection. As we'll see in a minute here, 24-hour urine collection is a pain. So if you're looking at a urinalysis result, whether you're actually holding the dipstick in your hand or you're reading the report, this is what your equivalents are in terms of how it's reported. So if you're looking at the dipstick and holding it up next to the bottle yourself, and you're looking for the color change that says it's plus whatever, or you actually get a report that says it's +1, +2, +3, etc. This is kind of what the range of protein in the urine is. So like I said, 150 milligrams per day is, or less, is considered normal. So is it theoretically possible that you could have a dipstick get tripped just by the presence of your modulator? Yeah, it's possible. It is possible. So this is an example of a 24-hour urine collection jug. They come in multiple shapes and sizes and colors. Most of the ones that I've seen have been opaque. And I don't know if that's by design to help prevent ultraviolet light breakdown of the constituents, but I have actually, in real practice, never seen a clear jug like this for 24-hour urine collection. The ones that we used to give at BAMC when I was on faculty there for our 24-hour URIS collection, the ones they would get from the lab were like blaze orange and opaque. You can see here why this is potentially problematic. So you think people are going to carry around the 24-hour urine collection jug on a work day? They're going to carry that with them to the office or to the field? Probably not. And do people's normal routines differ between a weekday and a weekend?
Yes.
Yeah. So having a patient do the collection on a Saturday or a Sunday is potentially going to give you different results than if you had them do it on a weekday. If they really have something significant going on, it shouldn't make that much of a difference, but it can. Collecting too much urine or not collecting enough, believe it or not, those two things can throw off the results considerably. So the instructions that we typically give to patients who are doing a 24-hour urine collection is that when they start the collection, when they get up that morning, the first void of the morning goes in the toilet. And then they collect every drop of urine that they make over the next 24 hours, including the first void of the morning the following day. And that's your 24-hour urine collection. If they collect the first morning void on both days, then you've got too much, and you then therefore have a greater than 24-hour collection, and so you're going to have a higher concentration of constituent products. Right? So it's going to throw off your results. So it's very important to make sure the patients understand exactly what they're supposed to do. In terms of 24-hour urine collection specifically for proteinuria, they also have to keep it refrigerated. Why do you think that is? Louder?
Bacteria?
So bacteria is a concern. If they have a urinary tract infection that they don't know about, or if they have normal flora that's there, and it might alter the contents if the bacteria is metabolizing what's there. But just simple decomposition of whatever protein might be present is going to be accelerated if the urine isn't kept cold, which is just another thing that patients don't like to do. I have to keep this jug of pee in my refrigerator next to my orange juice and my eggs. Yes, you do. And then how do they do that at work? So I've actually seen people doing 24-hour urine collections with an ice chest. So they decided that they weren't going to do it on the weekend, or they couldn't. There was something prohibitive in their schedule. They had plans, and so they took it to work, and they were carrying around an igloo cooler. And I'm dating myself because I didn't say, like Yeti. But carrying around a red and white igloo cooler with ice in it and their 24-hour urine collection jugs so that they can collect everything. It's also very important to make sure that patients are given something more convenient to do that actual urine collection in. Does it look like from the mouth of this jug that it's easy to urinate into it? Especially if you're female? So for females who are doing a 24-hour urine collection, we typically give them toilet hats. So they put the toilet hat in the toilet, they urinate into the hat, and then they use that to transfer it into the bottle. For males, we'll usually send them home with one of those nifty handheld urinals like you see at patients' bedsides when they're inpatient and maybe can't handle it to the bathroom very well. And so you just got to make sure they go home with something that they can do that with. All right, so if you're talking about just a spot sample, if that's all you have access to, then you can calculate a urine protein creatinine ratio. So this is assuming that you have more than a dipstick, right? Because the dipstick's not going to tell you exactly how much protein is present. So you have to actually get a laboratory evaluation of that single urine specimen to find out what they have in terms of how much albumin is present in their urine, and then you can calculate the urine albumin ratio. And it's good for screening in diabetic patients, especially if they've already had some sort of a baseline evaluation and you're just looking to see how their renal function is maintaining itself. Then this is a much simpler way to do it than having them repeat a 24-hour urine collection. And then protein creatinine ratio, if you don't have an albumin level, but you do have just a whole total protein level, then you can do that as well. All right, so other things that you're going to be checking on patients that you're evaluating for proteinuria, self-explanatory for a lot of it, right? So a metabolic panel or renal function panel, a lipid panel. The lipid panel is not necessarily directly related to the proteinuria, although it can be. You're getting a lipid panel for two reasons. One is in case they do have something that causes lipid dumping and proteinuria, like we talked about renal tubular acidosis yesterday and Fanconi syndrome. In that incident, then a lipid panel is sort of directly related. But if you're talking about a diabetic patient, you're interested in their lipids anyway, right? Or a patient with cardiovascular disease. You can do protein electrophoresis. This is something that they might do in conjunction with a 24-hour urine collection anyway, just to see exactly what protein is there and break it down for you by constituents. You may do a renal ultrasound and or renal biopsy, depending on what you find. So, like we talked about before, a renal biopsy is the only way to confirm for sure what type of renal disease a person has. So that is probably going to be one of the final steps in your process. Once you've established that there is something significant going on, then you'll do a renal biopsy to confirm the diagnosis. So if they have significant proteinuria, then they may present with generalized edema or anasarca, right? So they'll be sort of puffy everywhere. And that's due to the change in osmotic gradient that's caused by the loss of protein. So if they're losing protein from the serum into the urine, then it changes their tonicity, right? And so that osmotic pressure, that normal osmotic pressure gradient isn't there. And so free water will then flow from the intravascular space to the extravascular space, and they end up puffy all over. I have some pictures later. I can't remember if it's in this slide deck or another, but you'll see that there's a picture of a child who's just puffy all over. Looks like they may have been, stung by a swarm of angry bees, and they're having an anaphylactic reaction. And then you can see here the risk of all of these various things goes up just by virtue of having proteinuria. Why do you think that they're at increased risk of thrombosis? Say again? Good thought, no, but good thought. So if their osmotic gradient has been altered and the fluid in their serum is being pushed into the intracellular space, what happens to the viscosity of the blood? The viscosity goes up. It becomes thicker. It's more like motor oil. And so anytime you have stasis of blood, you have an increased risk of thrombosis. So how do you treat it? If they've got hypertension and proteinuria, it's actually more important to get their proteinuria under control than it is to get their blood pressure under control, believe it or not. And using an ACE or an ARB, while that will have an effect on their blood pressure, it also has a direct effect on their protein excretion in the urine. And your goal is to get their proteinuria to less than 0.5 gram per day, which might be easier in somebody with a nephritic syndrome than somebody with a nephrotic syndrome, because if you're dumping greater than 3.5 grams of protein per day, it can be much more challenging to get them below that threshold. But ACEs and ARBs, because they work by reducing intraglomerular pressure, that ends up reducing protein excretion. So they don't end up forcing as much protein through the glomerulus due to the reduction in efferent arteriolar pressure. Okay. So weight loss can be helpful. It's challenging. If you're seeing a patient who's got high blood pressure and heart disease, diabetes at baseline because they're overweight, they've been that way for a while, getting them to lose that weight can be challenging, but it is helpful, significantly helpful in some cases, especially if they're aggressive about it. And then dietary protein restriction might be of some benefit, but you might have a patient who already has a fairly low protein diet and has a nephrotic syndrome. And so in that particular case, having them limit their protein intake isn't really going to help all that much. And then all these patients should be referred to nephrology. If they've got a nephritic syndrome or nephrotic syndrome, they've got medical renal disease and they need to be managed by a nephrologist. All right, so as far as, and I can't claim responsibility for this slide, this is one that I inherited, but medications that are new kids on the block for treating proteinuria include your SGLT2 inhibitors, and here's the mechanism of action for your SGLT2 inhibitors. There's not going to be anything about this on the exam. Just know that SGLT2 inhibitors have a favorable outcome on proteinuria. And then your GLPs. So we're learning more and more about GLP-1s and benefits that they have from a sort of a whole body standpoint. So they initially came out as diabetes medications, right, used for reducing patients' blood glucose. But we now know that they are significantly beneficial for weight loss. I'm sure everyone has seen commercials on television for Hims and Roe and what have you, these telemedicine organizations that will provide GLP-1s. Oprah Winfrey is on a GLP-1. We also know that, and this was recently published research, that GLP-1s can be used to treat non-alcoholic steatosis. So somebody who has fatty liver disease that's not due to alcohol abuse, they actually have significant reductions in fat deposition in the liver. So just be aware that as research continues to be conducted on GLP-1s, that you're going to see more and more applications for those medications. In this particular study, which was published in the New England Journal of Medicine, which you may have heard of, one of those non-predatory journals like we talked about in research evaluation. I'm being a little bit facetious here. The New England Journal of Medicine is one of the top tier publications for medicine in the United States. They found that semaglutide reduced the risk of clinically important kidney outcomes and death from cardiovascular disease in type 2 diabetics and patients with chronic kidney disease for other causes. So you may end up seeing these medications get additional actual FDA indications. So there's already an FDA indication for weight loss. So I mean, it's not an off-label use for GLP-1s anymore. It's an FDA-approved use for weight loss, not just diabetes anymore. And there's actually an FDA indication for treating fatty liver disease. So where they started using these medications as an off-label, hey, we think this is going to help, the research has actually shown that it does, and the FDA has agreed with that. So here's, if you don't know how GLP-1s work, here you are. So the effect of GLP-1s is to increase, among other things, a sense of satiety, right? So patients don't feel like they're as hungry, so they don't eat as much. But we're learning more and more about the direct effect that GLP-1s have on other organ systems as these research studies continue to be conducted. And again, you're not going to have pharmacologic or biochemistry questions on either of my exams. So this is really more for your reference than it is for anything else. Okay, so that's proteinuria. Any questions? So just to review, if you have a patient who you incidentally find has proteinuria, or they have an underlying disease process that you think is going to increase their risk of developing renal disease, like poorly controlled diabetes, then you're going to do spot urinalysis. You're potentially going to do a 24-hour urine collection. And you're going to do all those other things that you would be doing to evaluate that patient anyway based on your underlying disease process. So lipid panel, renal function panel, that sort of thing. That's how you evaluate it. And then if you find proteinuria, what do you do with that patient? Right, refer. So you might go ahead and start them on an ACE or an ARB, especially if they've got high blood pressure. They may already be on one, depending on how sick they are and how long they've known they're sick. But if they haven't been seen by nephrology, you're going to refer them to nephrology. All right, so hematuria. Again, we've talked about hematuria before, the presence of red blood cells in the urine.
Cancer.
Right, I heard somebody say cancer, yes. So there are lots of things that can cause hematuria. The thing that I worry about the most is cancer because that's what's in my wheelhouse. But there are lots of other things that can cause hematuria. And just a reminder, if you get a point of care urinalysis on somebody where all you have is a dipstick, and it says that there's quote unquote blood, it's not blood that it's looking at, it's the presence of hemoglobin, and there are other substances that can cause the hemoglobin box to trip. So myoglobin will do it. The point is, you can't diagnose somebody with hematuria just based on a dipstick. You have to have microscopy. Even if you're looking at their urine specimen and you're like, oh, this is red, just because it looks red to the naked eye doesn't mean that what's causing it to be red is blood. So you have to get microscopy to actually determine for sure that someone has hematuria. Now, if somebody comes in with gross hematuria and they have a definite reason to have gross hematuria, like they just had surgery on their urinary tract, then you can be reasonably confident that what you're seeing is blood. But if it's somebody who just comes in off the street and they've got red urine or pink urine, then you want to actually determine that what they've got going on is blood. Dipsticks are very sensitive, but the problem is that they're sensitive for other things as well, not just hemoglobin specifically. In a pinch, let me go back one slide. In a pinch, if you have the dipstick in hand and you're able to look at it with your own eyes, and the hemoglobin box is not completely color changed, but it just has individual little spots that have changed, that can be a surrogate decision-making point for you. You can look at this and say, I think they probably do have blood in their urine because individual cells have hit this dipstick and caused just this spot to turn color. But again, it's not a slam dunk. It quote unquote won't hold up in court, if you will. So you need to get that microscopic evaluation to be sure. So microscopic hematuria greater than 3 red blood cells per high-powered field. Technically, you're supposed to confirm that with 2 out of 3 properly collected samples, 1 week apart. Again, how often do you think that actually happens? Not very often. Usually, you get that urinalysis with microscopy, you see that they've got hematuria, and you just start going into a hematuria workup. Lots of things can cause blood in the urine. Calculi, cancer, infections, trauma, intrinsic renal disease. All of these things can cause blood in the urine. So finding the blood in the urine is just the first step in trying to figure out what's going on with the patient. And as we keep saying, if it's painless gross hematuria in an adult, especially if they're over the age of 40, then you need to be thinking about malignancy until proven otherwise. And I can tell you that age cutoff of 40, don't hold that in your head as like a pathognomonic, this is a cut line that they have to be passed. I have seen patients in their 30s with really, really, really severe bladder cancer. It's unusual. The particular patient that stands out in my mind is somebody who had been treated for another malignancy with cyclophosphamide, which is a chemotherapeutic agent, which also increases your risk of bladder cancer. And she developed bladder cancer. So don't say, well, they're not over the age of 40, so I don't need to worry about it. You still need to worry about it, but your warning bells need to be going off a lot more if they're over the age of 40. So you can get red blood cells into the urine from anywhere in the urinary tract, right? Because the entire urinary tract is vascular. I mean, the kidneys are just giant balls of blood vessels. That's all they are. And knowing where the hematuria occurs when the patient voids can be helpful, but it's also a piece of information you're not likely going to be able to elicit from the patient. This is standard teaching, initial hematuria versus terminal versus total, but I have asked patients this question for my entire career: when does the blood in your urine occur? And 9 times out of 10, they're not able to tell you. It's particularly challenging in female patients since they avoid sitting down, so they're not looking at their urine stream to know when it started. They just know that there's blood in the bowl, or they find blood on tissue paper after they wipe. And males just don't pay attention. But for academic purposes, if the blood is only at the initiation of the stream, so the first little bit of urine that comes out is pink or red, and then it clears, then the source of the hematuria is probably distal. Think like penile urethra. If it's terminal, so the initiation of the void is clear, and then it turns red by the end, then you're thinking that it's going to be something higher in the urinary tract. Probably prostatic or bladder. And then if it's total, well, that may mean that their bladder just filled with, or I shouldn't say their bladder filled with, but their urine just became totally tinged with blood from wherever the source is, whether it's the kidneys, the ureters, the bladder itself, or it's a bladder upper tract source. And you can see that there's examples given here. So strictures can just in and of themselves, so if somebody has a stricture somewhere in the urinary tract, they can bleed. But I have not ever diagnosed somebody with a urethral stricture or a ureteral stricture just based on the presence of hematuria. More often than not, it's going to be an intrinsic renal disease problem, or it's going to be a stone, or it's going to be cancer, or in an older male patient, it might be BPH. As the prostate enlarges, the the prostatic urethra ends up developing varicosities, and just the turbulence of urine passing by those varicose veins can cause them to rupture, and then they'll have gross hematuria. So like with everything else that you talk about in evaluating a patient, you want to know about the onset, the duration of symptoms, the severity, any associated symptoms. So if somebody's got hematuria and flank pain, what's the first thing that comes to mind? Kidney stone, right? Smoking history is very important when you're talking about the evaluation of hematuria, because tobacco exposure is the #1 risk factor for urologic malignancies anywhere in the urinary tract. So, at face value, does it make logical sense that the tobacco exposure increases the risk of urologic malignancy? Just like if you're comparing the urinary tract to the lungs, does it immediately make sense that tobacco exposure should cause an increased risk of genitourinary cancers? Nobody smokes with their kidneys, right? So why does that happen? And I know it's a smoking history, but it's really tobacco exposure. Why is tobacco exposure a risk factor for genitourinary malignancies?
Nephrotoxic?
Okay, I'm hearing less oxygen. What else?
Nephrotoxic?
So it's the toxic aspect of it. So when you inhale cigarette smoke, for example, the toxins in the cigarette smoke directly impact the lungs because they're going into the lungs, right? But those toxins then cross into the bloodstream through the alveoli. How do they get out of the bloodstream? They're filtered in the urine. So that's why there's an increased risk of genitourinary cancers as a result of tobacco exposure, whether it's smoking or dipping, because whatever got into the bloodstream has to get out of the bloodstream. And there are other things that increase risk of genitourinary cancers besides smoking. You see like these occupational exposures. So aniline dyes, yes. So nicotine in and of itself is not carcinogenic. Nicotine by itself. So everyone who's got Zyn and Velo and what have you. Now, vaping is just as bad, if not potentially worse, from a lung function standpoint. The jury's still out on whether or not vaping has the same effect from a genitourinary cancer standpoint. But we know that vaping can be just as bad, if not worse, for the lungs as tobacco smoke. But nicotine in and of itself is not carcinogenic. It does increase blood pressure, but so does caffeine. So there's no known risk of increased chances of malignancy just from nicotine usage. So aniline dyes, when they still teach this, you might still see questions on standardized exams where they'll give you a presentation of a patient who comes in with hematuria, and on questioning you find out that they work in a textile mill. Human beings, except in maybe like craft industry or hobbies, don't do a whole lot of fabric dyeing by hand anymore. If you go to, say, the Levi Strauss & Company factory and look at how they dye their denim, it's not some person dipping denim fabric into a tank of dye with their hands. They're not handling the wet fabric as it comes off the line anymore. It's all done mechanically. But aniline dye exposure does increase the risk of genitourinary cancers. Aromatic amines, so we're talking like paint thinner, you're talking things like cyclic hydrocarbons. So in our patient population, the people that you need to be thinking about are people that worked on a flight line and were exposed to aircraft exhaust all day, every day. So air crews and the actual flight line personnel, whether they were petroleum oil lubricant handlers and refuelers, or if they were just out there directing traffic. Same thing for people who work in motor pools. So if they're exposed to vehicle exhaust for long-term exposure and high concentrations, then that's something that's potentially going to increase their risk. And then another thing that you'll see often on standardized test questions is there's an analgesic that used to be prescribed a lot in the early 20th century that has not been on the market since like 1950, called phenacetin, which sounds a lot like acetaminophen, right? It's not. It's not the same thing. Phenacetin, and the reason it's not on the market anymore is because it causes bladder and kidney cancer. But you will still occasionally see questions where you get this old patient that comes in and is like, I used to take phenacetin, and chances are that's not gonna, you're not gonna see that pop up as much. You're certainly not gonna see it on one of my exams, but just know that there are medications. Cyclophosphamide is one that is still used very frequently that you might see as something in a question. But phenacetin was an analgesic that was used a lot that caused genitourinary cancers. And then you need to know about their prior history of renal and or urologic disease, because anything that affects the kidneys or the urinary tract writ large is potentially going to cause hematuria. So do they have dysuria? Do they have other symptoms of bladder irritability? So they got urgency, frequency. We talked about this, I think it was in the first lecture. If somebody has dysuria, urgency, and frequency, are you guaranteed that they have a urinary tract infection?
No.
No. They could have overactive bladder. They could have a tumor. They could have a stone. All of these things can potentially cause those symptoms, but it is something that you need to make a note of when you're working up a person's hematuria. If it's completely asymptomatic gross hematuria, we know that the thing we need to be thinking about is a malignancy. If they have gross hematuria and they've got, a fever and dysuria and urgency and frequency, and they don't have any other risk factors, is it more likely to be a malignancy? Is it more likely to be like complicated cystitis or raging pyelo? It's probably going to be one of those. Urethral discharge, yeah, chlamydia, gonorrhea, those things can cause hematuria as well. You need to know if they've got whitish or greenish discharge. You need to know about their sexual history. And then trauma obviously can cause blood in the urine. We've talked about that quite a bit. And then I know we talked about menstruation being a confounding factor. So, if you have a patient who you need to get a urinalysis on, or you've gotten a urinalysis on, make sure that they're not menstruating or haven't recently stopped their menstrual cycle, because it could just be contamination from that. And then depending on how they present, you may consider doing an abdominal exam, a pelvic exam. If you've got somebody who has a recent new sexual partner and their presentation lines up with potential for a sexually transmitted infection, then you might do a pelvic exam. If you suspect a prostatic source, you might do a rectal exam. So renal or extrarenal. So when we say renal, we're talking about things that are literally in the kidney, with the parenchyma of the kidney, right? So is it medical renal disease? Is it nephritic syndrome? Is it a nephrotic syndrome? Sometimes simple renal cysts can bleed, and then they end up with blood in the urine, either microscopic or gross, and of course neoplasms. And then extrarenal. So a renal calculus, even though it's in the collecting system of the kidney, it's still an extrarenal cause, because it's not the kidney itself that is the source of the blood, it's the stone causing it. So, and then extrarenal neoplasms. So renal cell carcinoma, or a transitional cell or urothelial cell carcinoma that has arisen from the collecting system is going to be a renal source, but a neoplasm someplace else in the urinary tract is going to be an extrarenal source. Questions about this? All right, so a mnemonic. Again, I can't take credit for this, but the differential for hematuria, PP on this. This can help you remember all the different things you need to be thinking about. as potential causes for hematuria, including some confounding factors. We've said it before, say it again. Look for things like fever, edema. Be thinking about a nephrotic syndrome. Do they have a costovertebral angle tenderness? Is there a kidney stone that's causing their hematuria? Do they have suprapubic tenderness? So can you have somebody who has a badly distended bladder because they're in retention who's actually still able to void some?
Yes.
Yes. If it's acute and their bladder has become badly distended over a relatively short period of time, beyond what its normal capacity would be, do you think that causes hematuria?
Yes.
Yeah. The mucosal lining can tear if you over-distend the bladder too soon. But the exam is often benign or unremarkable. More often than not, if you're working of an isolated case of hematuria, their exam is going to be normal. So I won't belabor the urinalysis. We've talked about this a lot already. First morning weight is best, but that's not practical most of the time. It's going to be whenever you get the patient to the lab or the clinic. Dipstick can detect as few as 2, but the dipstick by itself doesn't answer the question. All of these things can cause false positive dipstick results, which is why you need a microscopic evaluation. And other things that can cause false negative dipstick results are ascorbic acid levels. So it just triggers the color change. So on the left, you see individual free-floating red blood cells. On the right side, what's that again? That's a cast. So that is a red blood cell cast that you see there on the slide. If it's a cast, what does that tell you?
Compressed cells.
Came from the kidneys because the cells were packed together in the tubules before they were excreted in the collecting system. And then look and see if they have concomitant proteinuria. And like it says, if it's glomerular hematuria, send them to nephrology. If it's non-glomerular hematuria, send them to me. Got to get that microscopy. Get a urine culture and sensitivity. Like we talked about before, you can have an otherwise completely normal-looking urine in a patient who's asymptomatic and they still have a pathologic organism growing in their urine that might be causing problems. So as part of your evaluation for hematuria, you should get a urine culture and sensitivity. And if it's positive, treat it and then recheck the urinalysis. Back again, urine cytology rearing its ugly head. Yes, it's in the workup chain, but it's probably not something that you should be doing for the reasons that we talked about before. If the results are truly positive or if they're questionable, patients are going to start asking you questions that you're not equipped to answer. So don't get a urine cytology. If you send a patient to us who needs a hematuria workup, we'll determine if they need a urine cytology and we'll take care of getting that. No one is going to fault you for sending a patient to urology without having obtained the urine cytology before they get there, because it's just not it's not worth opening Pandora's box. Now, when they finally get to us, remember we talked about CT urography? I know we really flew through the imaging studies for the urinary tract, so we'll talk a little bit more about this. Give me 5 more minutes, guys, and then we'll break for 10. So the CT urogram, just to review what we talked about before, it's a 3-phase CT scan, non-contrast, then a vascular phase or arterial phase, and then an excretory phase. And that shows us everything that we need to know about the urinary tract. Non-contrast phase is going to tell us if there's calculi present. The arterial phase is going to tell us whether or not there's a renal mass. And the excretory phase is going to show us if there's any filling defects in the ureters. And then we'll also do a cystoscopy if the patient meets the criteria. So when I started my training, everyone with hematuria, whether it was microscopic or gross, got a CT urogram and a cystoscopy, period. everyone got the same evaluation. And in some of the more recent updates to the standards, they've actually done risk stratification. So if you have a 29-year-old with no risk factors who has microscopic hematuria, you don't have to tell them that they need a cystoscopy anymore. Some patients will opt for it anyway. They can't wrap their head around the idea that there might be something bad going on in their lower urinary tract, and they just need to know, they want to see that there's not something bad in their bladder, and they'll say, I want that cystoscopy. So then we call that passage of therapeutic plastic, because we're not actually doing anything for them, we're just putting their mind at ease. But in the past, it was everybody gets a CT urogram, everybody gets a cystoscopy. So you can see in the CT image in the upper right-hand corner, this is an infarct. This is not a tumor. You can just see that there's a segmental infarct here. You can't tell from the picture whether or not this is due to pyelonephritis or did they actually just infarct part of their renal vasculature. But half of the kidney's not being perfused on that side. And then this is a blood clot in the urethra. So this is what you would see on a cystoscopic view. So as I mentioned, risk stratification. So these are your low risk patients, intermediate risk, and high risk. If they're low risk, then they may not even necessarily need a CT urogram. They might end up just getting a renal ultrasound. If they're high risk, they're going to get the whole workup. Questions about this? All right, so if their hematuria is persistent, so if you've already referred a patient to urology for a workup of hematuria, we're going to hang on to them. We're going to have them come back for periodic evaluation, especially if they're high risk, to make sure that they don't develop something that just was subclinical at the time that they were referred. Nephrology is probably going to hang on to them as well. But if you think back to that whole, get 3 urinalyses, if 2 out of 3 are positive, then that's what they mean by persistent hematuria. If they have a positive urinalysis for microscopic blood confirmed on microscopy on 2 out of 3 evaluations, then it's persistent and you need to refer them. But functionally speaking, you're going to find it, you're going to confirm it, and you're going to refer it once you determine whether or not it's a nephrologic, medical renal disease source or urologic source. So here's your flow chart for referral. Everything we've already talked about. Pseudohematuria. Again, lots of things can cause the blood to appear that it might have, or excuse me, the urine to appear that it might have blood in it that isn't necessarily blood. Beets, believe it or not, can change the color of the urine just like it can change the color of stool. So somebody who had a beet salad before they, went in to give a stool specimen, they might have what looks like blood, and it's actually not. And then myoglobin, so rhabdo, blunt trauma, electric shock, ATN, these things can cause an appearance of red or brown urine, but it's not blood. Drugs that can change the color of the urine, we've talked about a bunch of these before. Rifampin, I mentioned specifically. Phenazopyridine, I mentioned specifically, but these are other ones that can potentially change the color of the urine and can make somebody think that they've got hematuria. And if we haven't hammered it home enough, there's your classic patient presentation that you might see on a PANCE question. Bladder cancer until proven otherwise. Questions? Okay, let's take a 10-minute break and then we'll get into AKI. So we've talked about a lot of the stuff in this lecture before in previous talks, so hopefully we'll be able to gloss over some things. But if I'm going too fast and you have questions, please raise your hand and stop me. Okay. I'm not going to read the learning objective to you. It's the same as it is for everything else, except now we're talking about AKI. So just to review, azotemia Abnormally high serum levels of nitrogenous substances. So when you hear somebody say that a patient is azotemic, this is what they mean. Uremia is the clinical syndrome that results. So azotemia is a lab finding. Uremia is a clinical presentation. People often use these terms interchangeably. Technically, that's not correct. Azotemia leads to uremia. So an acute kidney injury, very straightforward. It's an abrupt reduction in GFR. An abrupt reduction in GFR, regardless of what the cause is. If they have an abrupt reduction in their GFR, then they have an acute kidney injury. And lots of things can cause that, and we'll talk about that in this lecture. Okay? Symptoms are nonspecific because everything we've talked to up to this point has been relatively nonspecific, right? So it makes sense that this would continue to be nonspecific. As glomerular filtration rate declines, tubular secretion of creatinine increases. So the longer that it takes the glomerulus to filter, the creatinine that is secreted goes up by virtue of time. So it's simply a matter of how long it takes the blood to get through the glomerulus. The longer it takes, so the lower the GFR, the higher the creatinine is going to be. And that's why in the early stages, it requires a large reduction in GFR to raise serum creatinine, because it has to get to that point where it's starting to diffuse more across the barrier. So look at the BUN creatinine ratio. That's going to give you more information, because they're going to have a much more rapid increase in BUN in an acute kidney injury than their creatinine is necessarily going to go up. So how do we define an acute kidney injury? An increase in serum creatinine of greater than or equal to 0.3 milligrams per deciliter within 48 hours, or an increase of 1.5 times higher their baseline that you know occurred within the past 7 days. So if you have a patient that you see for an annual well check, and then they end up in the emergency department 5 days later, and you have those two lab values to compare to each other, then that can give you your definition. That can meet the definition of AKI. Or if they have a urine output less than 5 milliliters per kilogram per hour for greater than 6 hours. So if they become oliguric, even if their laboratory values don't change, or maybe you're in an environment where you don't have the ability to do lab work, but you can monitor their I's and O's, then this is also indicative of an acute kidney injury. There's 3 stages of AKI. I'm not going to ask you to define the stages of AKI on an exam, but just so you know, stage 1 is the mildest stage, obviously. Stage 3 is the most advanced. 1.5 to 1.9 times baseline, or that greater than 0.3. Serum creatinine 2 to 2.9 times baseline, or a decrease in urine output. So these definitions also fall into different stages. So just know that as well. And then stage 3 times baseline, or an increase to greater than or equal to 4 milligrams per deciliter. So if their creatinine is 4 or higher, then it's stage 3. Or if they're anuric for greater than 12 hours. Obviously that's a problem, right? And if they get put on renal replacement therapy for any reason, then you're going to say that they have a stage 3 AKI. And we'll talk about, so we've talked about dialysis, but we'll talk about chronic renal replacement, or excuse me, continuous renal replacement therapy later on. So serum creatinine is the gold standard, but it's problematic. We've talked about all that before, why that is. So if you're looking for an ideal biomarker for determining if somebody has acute kidney injury, We talked about cystatin C. The reason that cystatin C is not ideal is because it is very expensive, and it's not easily done at most labs. I think I mentioned this before. If you order one at BAMC, it's a set down. They don't even do them in-house. They send them to LabCorp, and it takes over a week to get the results back. So that doesn't really help you a lot for your acute kidney injury patient. So, where does acute kidney injury occur? These are the questions you have to be asking yourself, and this is what we're going to get into. So pre-renal, as the name implies, means that the problem is before the kidney. So, giving an example of a pre-renal cause for an acute kidney injury. There's one in particular we've talked about ad nauseum in our patient population. So dehydration or hypovolemia due to trauma. Yeah. So if their volume down for whatever reason, then their perfusion of their kidneys is going to be impacted, and that's going to cause a pre-renal AKI. Intrinsic renal disease is anything that happens in the kidney itself. So your nephrotic syndromes, your nephritic syndromes, these are examples of intrinsic renal disease, not necessarily something that's going to cause an intrinsic acute kidney injury, although they can. But those are your examples of intrinsic renal disease. So acute tubular necrosis. And then post-renal azotemia is anything that happens after the kidney. So think kidney stones, think malignancies that are impinging on the ureter, think somebody who's in acute urinary retention and can't void. These are all things that are post-renal causes of azotemia. So here's your diagnostic flow chart for approaching acute kidney injury. We'll get into these things as we move through the lecture. So addressing an acute kidney injury is important because if you don't, and the problem persists, you can see that things just get worse with time. Right? The further along you get, if you get past the window for early targeted intervention, you get on towards death. And at every single one of these levels, you have complications that can occur, and then they build upon themselves, which just accelerates things towards death. And we're not necessarily talking about the death of the patient, although I mean that can happen. We're also talking about death of nephrons. And nephrons you can't replace easily. Okay, so we've talked about this already, but just if you need a graphical demonstration, pre-renal is before the blood gets to the kidney, intrinsic in the kidney, post-renal after the kidney. So pre-renal causes are the most common because there's so many of them. I mean, there's just so many things that can impact renal perfusion that by default is the most common cause of AKI. And it's anything that causes renal hypoperfusion. And if you can correct that, then long-term damage might be avoided. So if you have somebody who is in septic shock or had a significant blood loss, you might see a bump in their creatinine, and as long as you address the underlying problem expeditiously, then they should recover their renal function. If they already have underlying renal disease, they may not or may not recover it as quickly, but they're already at increased risk of having whatever damage that occurs be more permanent or become additive to whatever their chronic kidney condition is. And if hypoperfusion is persistent, then it can end up leading to an intrinsic kidney injury. So what started as a pre-renal cause can end up causing intrinsic AKI because the glomeruli themselves have actually been damaged. And it's not just an issue of perfusion anymore. So we've talked about a lot of these just to highlight some that we maybe have not talked about. So pancreatitis, burns. How do burns cause a pre-renal AKI?
Hypoventilation from the loss.
So massive fluid loss. So two of the most important things that your skin does for you is it helps you thermoregulate, and it also keeps you from drying out. So if you lose skin in large quantities, then you start losing fluid as well. So it's not just as simple as, like, somebody got a second-degree burn and they blistered. If you don't have skin covering your subcutaneous fat or your muscle, you just start turning to jerky. I mean, the fluid loss is insane. Burn patients, especially burn patients with extensive burns, require extremely aggressive fluid resuscitation. In case you don't know, this is a little bit of a tangent, there are two main formulas for calculating fluid replacement for burn patients. One's called the Parkland formula, which is named after Parkland Hospital in Dallas. The other one is the modified Brook. So Brook Army Medical Center, at the Institute of Surgical Research, the burn ICU, has its own published formula for calculating fluid replacement in burn patients. Things that change vascular resistance. So in a septic patient, they're not hypovolemic per se, but they're hypotensive, and so they have decreased vascular resistance. Anaphylaxis can do it as well. If somebody takes too much in the way of afterloading drugs, like a blood pressure medication, then that can do it. And then low cardiac output. So we'll talk about cardiorenal syndrome and hepatorenal syndrome later on, but the crux of it is, if you have dysfunction in one organ system, it can lead to dysfunction in another. So in the case of low cardiac output, if somebody's in heart failure and they're just not capable of pushing out as much blood to the body as they have been in the past, then that results in poor renal perfusion, which results in an AKI, which then puts more strain on the heart, which then puts more strain on the kidneys, and it becomes this vicious cycle. And so cardiorenal syndrome and hepatorenal syndrome are things that can be very acutely terminally ill, can cause patients to become very acutely terminally ill. Okay, so I want everybody to read this slide. We're going to discuss it on the next slide. So I'll give you just a few seconds to read it. The crux of it is, what may be the danger of somebody taking an ACE inhibitor and an NSAID at the same time? What do you think?
Opposing effects.
So the end result is that the kidney ends up not getting enough blood. You end up with renal hypoperfusion. So the NSAIDs have an impact on the afferent arteriole, and the ACE inhibitor has an impact on the efferent arteriole. So you end up with not enough blood coming in and too much blood going out. So the point is, be cautious when you're prescribing multiple medications to patients, and be aware of what they're taking. Because if you have somebody who's on chronic NSAIDs and they've got elevated blood pressure, you might want to be cautious in providing them with an ACE inhibitor. Right? You might want to be thinking about some other antihypertensive medication that doesn't have its effect directly on the glomerulus, like perhaps an ARB. So, building on what we talked about in hematuria, obviously this doesn't look like normal urine, does it? But is it blood? Maybe. We don't know. It could be blood, it could be myoglobin, it could be renal tubular cells. We don't know. The point is, their urine's probably not going to look normal. And then clinical findings will be dependent on stage and potentially underlying condition. And then you see here what symptoms can be caused by uremia. The pruritus, that can be really, really pronounced. I have seen patients who had a bad kidney injury and became significantly uremic, and they were just itching like crazy, like they just couldn't stop scratching. It can be pretty impressive. And then hypertension and impairment of fluid homeostasis, which we talked about before. So whether it's a pre-renal cause, an intrinsic cause, or post-renal cause, you need to know what their history of current renal disease is, because if they already had baseline renal disease, the likelihood that they're going to have a worse effect and potentially worse outcomes is higher. And then, like we talked about before, when we were talking about hyponatremia and fluid electrolyte status, look for signs of hypovolemia, because if they are hypovolemic, that's a relatively easy fix in the grand scheme of things. If they're fluid down, you're going to see things like increased skin turgor, collapsed neck veins, dry mucous membranes, things of that nature. So, in a pre-renal AKI, BUN creatinine ratio, we talked about this already, is important to look at, because it's relatively easy to calculate, or it's relatively easy to get, right? If you get a renal function panel, you're going to be able to calculate a BUN creatinine ratio. Most of the time they do it for you. To get a urine osmolality, you're going to have to order that separately. If you do a urinalysis, which you should be doing because their urine doesn't look right, they'll tell you what's in it, and you may see bland or hyaline casts. So these are the same thing. This is just the terminology. They may say bland casts, they may say hyaline casts. So a bland or hyaline cast is a cast that doesn't have any cells in it. So it's visible. Think about like an icicle. So it's like there will be a tubular structure that will be visualized on the urinalysis, but it doesn't have any cells in it. Their specific gravity is going to be low, their urine sodium is going to be low, and their fractional excretion of sodium is going to be less than 1%. And this really helps you differentiate between pre-renal and intrinsic disease. So this is a situation where calculating your fractional excretion of sodium is very helpful. So if you don't know if the patient has pre-renal azotemia or if they've got an intrinsic problem that's causing their AKI, calculate their fractional excretion of sodium, and that'll tell you where they're at. So more often than not, these patients are going to get admitted. Oftentimes this happens in patients that are already admitted. So they get admitted for some other condition, and their concomitant medical problems end up resulting in them developing an AKI. But you may have somebody who comes in, again, using this example, they come in for just a well annual check, and you look at their labs and you're like, oh boy, your creatinine took a hop. We need to get you admitted and figure out what's going on here. So if they're not euvolemic, you want to restore euvolemia, fix any pH abnormalities that they might have. So if you're talking about a septic patient, you're going to be treating their underlying infection, managing their acid-base disorders, and pay real close attention to their serum electrolytes for all the reasons that we talked about in the previous electrolyte lecture. And then monitor their urine output. If their urine output doesn't pick up with fluids, whether that's PO fluid intake or you're giving them IV resuscitation, then that's potentially a problem. So remember, AKI can take a little while to demonstrate to you that it's there. If all you're tracking is creatinine, it can take a while for that creatinine to bump in the face of a decreased GFR. And so if you're giving someone fluids, then their urine output should pick up accordingly. If it doesn't, that can be an early indicator for you that they're going to continue to get worse before you necessarily see that on their laboratory values. And then it probably goes without saying you should avoid nephrotoxic drugs. If they've already come in with a kidney injury, you probably, unless you absolutely have to, shouldn't be treating their sepsis with gentamicin, for example. Okay. So post-renal AKI, anything that causes an obstruction. So the example in this diagram here is a stone. So normal on the left, and then you've got a stone that gets down to the ureteropelvic junction and causes an obstruction. The kidneys don't know to stop making urine in the face of an obstruction because they're just dumb filters. They just keep right on going, and the pressure builds, and that causes dilation of the collecting system, which puts pressure on the renal parenchyma, which decreases glomerular filtration, which causes an acute kidney injury. And it can be an obstruction anywhere. So urethral obstruction, bladder dysfunction of some sort. Remember we talked about spinal cord patients, and what used to kill them was renal failure because they couldn't manage their bladders anymore until they came up with the idea of clean intermittent catheterization. So if you have a spinal cord patient who can't urinate, give them enough time, they'll get a acute kidney injury, which will turn into chronic kidney disease, and then they die. Obstruction of both ureters. How often do you think it happens that somebody passes a kidney stone on both sides at the same time? It happens. It's not super common, but it happens, and that becomes a surgical emergency. So a unilateral kidney stone is not a surgical emergency unless they only have one kidney. So if they've got a solitary kidney and they've got an obstructing stone, that's an emergency. If they've got two kidneys and they've got obstructing stones on both sides, that's an emergency. BPH, patients can get to the point where their prostate is so enlarged that they just can't go to the bathroom anymore. And we as practitioners can actually make it worse if we either don't know the patient has BPH or we know that they have BPH and we see somebody for allergies and we give them something with Sudafed in it. So what class of medications do we use to treat BPH symptoms? Or you can give me a specific drug. Okay, yes. So alfuzacin, tamsulosin, these are all alpha blockers, right? Alpha agonists. If you give somebody, not an alpha agonist, I'm backwards in my head. If you give someone an alpha agonist, you're going to have the opposite effect. So if an alpha blocker relaxes the smooth muscle tissue in the prostate to allow somebody to urinate more easily, if you give them something that's got an alpha agonistic effect, you cause those smooth muscle fibers to contract. And you can actually put somebody in urinary retention by giving them an alpha agonist. There used to be commercials on television for antihistamines that were specific for people with high blood pressure. Like one it was one that was a brand name was Coricidin. It was Coricidin BP was the brand name, and it was an antihistamine for people with high blood pressure because it didn't have Sudafed in it. But there have also been drugs that have been specifically marketed as over-the-counter allergy remedies for people that have BPH because it's a known problem. If you have somebody who has gross hematuria, you can have blood clots that are large enough that they end up causing obstruction. So if it's an upper tract source, they can block the ureter just like a stone does. If it's a lower tract source, they can end up blocking the urethra, and then they can't urinate, and they end up in the same situation as if they had BPH. And then papillary necrosis, if somebody has acute tubular necrosis that gets far enough along and they actually start sloughing papilla, then the papilla will break off from the collecting system and potentially block the ureter in the same manner that a stone does. So clinical manifestations usually occur late in the process. So they're not, unless you have a very sudden, very significant obstruction, like a patient goes into florid urinary retention, then you're not necessarily going to see signs until things have been present for a while. We talked about the fact that if you leave a kidney obstructed for a long enough period of time, the damage done can be permanent, and that's what I mean. So if you relieve the obstruction, they may not ever have any outward signs that there was something wrong. They may not develop an AKI, but if you leave the obstruction in place and damage starts to compound, then you can end up with actual signs and symptoms. It is unusual for patients to end up anuric unless the obstruction is at the level of the bladder or lower, or they have a solitary kidney. Right? They should still be, if you completely block one kidney, the other one's still going to make urine, so they're probably not going to become anuric. If they do become anuric, that's a problem. And they may have lower abdominal or back pain because of massive distension of the bladder. So, again, BU and creatinine ratio, their urinary sediment is still going to be bland. And then their fractional excretion of sodium is variable. So it depends on whether or not this is an acute onset problem or if it's something that's been present for a while and getting worse. Remember, a fractional excretion of sodium is most useful for determining between intrinsic and pre-renal. So it doesn't necessarily help you as much with post-renal AKI. Admit them. You're probably going to be consulting urology if it's an obstructive problem, because nephrology doesn't do anything to unobstruct the urinary tract. And then identify the source of the obstruction if that hasn't already been done. And how you do that will depend on what you suspect is going on. Also, if the renal function is already bad, you're probably not going to be getting a CT scan with contrast, right? So you could do a non-con CT, or you could do a renal bladder ultrasound, MRI if necessary, and then relieve the obstruction based on where it's located. So if it's BPH, hopefully you can pass a catheter and decompress the bladder and get it draining. Post-obstructive diuresis is a real problem, okay? So if you have somebody, this is more of a problem than somebody who's been obstructed for a while. So if you have somebody who just went into acute urinary retention because they took Sudafed, they're probably not going to have a post-obstructive diuresis. But I think, did I tell you guys about the patient that I put a catheter in at Methodist, who I got nearly 4 liters of urine out of after I put the catheter in? Did I tell you that story? So we'll talk more about it in the urology block, but that is an example of a patient who was in retention for a long period of time. If that had happened acutely, his bladder would have just ruptured. This is something that had been building over time. When you finally relieve an obstruction that's been present for a while, patients can develop a post-obstructive diuresis. And the knee-jerk response to that is, oh, I need to replace the fluids that they're losing. If you do a one-to-one fluid replacement, it actually precipitates the problem and keeps it going. And they'll just continue with that post-obstructive diuresis. So if they're not obtunded, all you need to have them do is drink to thirst. That's it. You don't need to give them IV fluids. You just need to have them drink to thirst. If they are obtunded, then you basically want to start at a benchmark of about a 50% replacement. So if they're losing a liter an hour in urine, then you only want to replace them at a rate of 500 cc's per hour. Because if you give them, if you replace it at the same rate they're losing it, it just propagates the problem. Okay. And the definition of a post-obstructive diuresis is 200 cc's per hour or greater of urine production. So if somebody's making 200 cc's an hour after relieving an obstruction, then they have a post-obstructive diuresis. So this person's got a problem. You might not necessarily know it just from looking at the picture, but then put a catheter in. This is not my patient, but I have done this. I have gotten almost 4 liters of urine. That was my record. It was 3,996 cc's is what we finally got out of that patient that I put the catheter in at Methodist when I was a resident. And then, again, have them drink to thirst. If they're conscious and they're able to drink, that's all you need to do is have them drink to thirst and keep an eye on their electrolytes, because their electrolytes can get way out of whack when they're going through a post-obstructive diuresis. So while you don't want to replace their fluid losses 1-for-1, you may need to replace their electrolytes if they're dumping a lot of electrolytes in their urine. Okay, intrinsic. So intrinsic kidney injury is the result of actual damage to the renal parenchyma, and your acute tubular necrosis is going to be the majority of causes there. But because it's easier to get after determining whether or not somebody has a pre-renal or post-renal cause, you're probably going to rule those things out before you start considering an intrinsic renal problem, unless they come in with a presentation that makes you go, oh, this is definitely an intrinsic renal problem. So acute tubular necrosis is caused by nephrotoxins, most commonly or you can see it in patients with acute interstitial nephritis or acute glomerulonephritis. Occasionally it can be vascular in nature. So if somebody, remember that CT scan I showed a few minutes ago, and I said, you know, this kidney is infarcted, we don't know why, but it is. If you eliminate the blood supply to a portion or all of the kidney, then the kidney starts to necrose, and you'll end up with tubular necrosis initially, and then that propagates to the point where you're sloughing entire papilla. So this is what acute tubular necrosis looks like grossly. So on this anatomic specimen here. And like it says on the slide, your two main causes are going to be ischemia, so an infarction of some sort, or due to somebody who's hypovolemic for an extremely long period of time, or hypotensive for an extremely long period of time. Remember I said that other sources of AKI, whether it's pre-renal or post-renal, can end up resulting in an intrinsic problem. That's an example. And then nephrotoxin exposures. So somebody who takes a whole bottle of ibuprofen, or they've been taking just too much ibuprofen over an extended period of time, they can end up with acute tubular necrosis. Aminoglycosides. If somebody has rhabdo, then rhabdomyolysis can cause acute tubular necrosis because the myoglobin is gumming up the works. Okay. So this is relatively self-explanatory, and we've talked about it a lot. So hypotension versus localized obstruction. So if somebody's hypotensive because of blood loss or because of sepsis, that's potentially going to cause ischemic ATN, or if you just cut off the blood supply. Okay. So what happens? This is getting into the nutshell, the nitty-gritty of what the underlying disease process is. So intravascular volume depletion decreases effective intravascular volume, which results in systemic vasodilation and renal vasoconstriction. And then you can have large vessel renal vascular disease. All of these things can result in ischemic ATN. And then anything that impairs renal blood flow. Any questions? Okay. The toxins can be endogenous versus exogenous. We've talked about a lot of this. Herbal supplements is one that you need to be mindful of, not just in our patient population, but the number of supplements that are available on the market have just exploded over the past 20, 30 years. And people just don't know what they're taking. You know, supplements are not FDA regulated, and so you always need to ask a patient if they're taking, when you ask if they're taking over-the-counter medications, you usually should follow that up with, how about vitamins and supplements? Because most patients won't associate the ashwagandha that they're taking with an over-the-counter medication. You need to ask them specifically, and there's a whole slew of them that are potentially nephrotoxic. Any questions about any of these? We've talked about virtually all of them, I think. Rhabdo, not to beat a dead horse, but when you have the profound muscle breakdown that's associated with rhabdomyolysis, the myoglobin has to be managed somehow, and that ends up being in the glomerulus, and that causes significant decrease in glomerular filtration and perfusion, which results in necrosis. More on rhabdo. We talked about all of this, I think. We talked about why it's a high anion gap metabolic acidosis. Anybody remember why? I heard somebody say unaccounted for. Yeah, so you have an unmeasured ion, right? And so that ends up causing a high anion gap. Okay, so tired of it as I am. Signs and symptoms of the etiology, whatever the underlying cause is. They may have generalized swelling, they may not. Oliguria in acute tubular necrosis can be an early sign, but sometimes even in acute tubular necrosis they don't develop oliguria. They can end up having polyuria. They're just dumping free water. They're not reabsorbing anything because the glomeruli have just been wiped out, and they're not doing anything that they're supposed to do. Muscle weakness and twitching due to electrolyte abnormalities, again from just dumping. So for acute tubular necrosis on your microscopic evaluation, instead of bland urinary sediment, like we talked about on our two previous situations, now you have active urinary sediment. You're actually going to see stuff in the sediment besides maybe bland or hyaline casts. So they may have muddy brown granular casts, which are casts that are made of renal tubular epithelial cells, or they may see just free-floating renal tubular cells. This is another one of those situations where if you're looking at it yourself, you're probably not going to be able to differentiate what kind of cell it is that the lab will tell you. If their urine output is high, that is actually a better prognosis than if they're oliguric or anuric. If they're oliguric or anuric, then the likelihood that they're going to recover their renal function goes down considerably. Their BUN to creatinine ratio is less than 20:1 because their creatinine starts to go up. And then their urine sodium and fractional excretion of sodium are going to be higher. And then they may end up with hyperkalemia and hyperphosphatemia as well. So 4 phases. There's the initial injury. Then you have the extension phase where the damage propagates. Then they get to a point where they're stable for whatever their situation is. So stability for one patient might be anuria. Stability for another patient might be oliguria or normal urine output. And then recovery phase. There is a high mortality rate associated with acute tubular necrosis. So patients that develop acute tubular necrosis, more often than not, have underlying medical problems that put them at increased risk. Now, if you're talking about somebody who's young and healthy and ran a marathon and got rhabdo, that's different. But most people that develop acute tubular necrosis have something else going on, and then there's one more insult that pushes them over the edge. And so mortality can range from 20 to 70%. I've taken care of quite a few patients with rhabdo. I've never had one die. But it's certainly a concern. I mean, there's a reason that we admit them to the hospital. So more details on the different phases. Okay. These minutiae are not going to be on the exam. Just know that the phases exist as I previously summarized it. And then here it is in graphical form if that's more helpful. Questions? You see here from this chart how long the process can be. I mean, you're talking about days, not hours, for someone to get through this process of getting through acute tubular necrosis. So they're going to get admitted to the ICU. If it's just straightforward rhabdomyolysis, they're probably not going to get admitted to the ICU, but they will get admitted. If they actually have acute tubular necrosis, then they're going to go to the ICU because they're going to have to be monitoring them closely. You want to manage their blood pressure. You want to maintain their fluid and electrolytes. So if somebody is anuric, are you going to be more aggressive or less aggressive with their resuscitation? Probably less, because you don't want to fluid overload them. If they're anuric, you can't thrash them with fluids because where's it going to go? If you overshoot the mark, you're going to have to put them on dialysis. And because that's the only way you're going to effectively get that fluid off of them. What happens if you give a diuretic to somebody who's anuric? Nothing. You don't jumpstart the kidneys by giving a diuretic to somebody who's not making any urine. Now, if somebody is anuric because they had significant trauma, which can happen. If somebody's really, really volume down because they lost a lot of their blood volume, then yeah, you're going to be more aggressive in resuscitating that person. That's an acute process. But when you're talking about ATN, if they're anuric, you got to be cautious with fluid resuscitation. Any questions about this? Okay, so if it's just straight up rhabdo, in that patient, you are going to be fairly aggressive with your fluid resuscitation because you want to dilute things and help the myoglobin move through. They also talk about giving patients sodium bicarbonate as part of their fluid resuscitation in rhabdo. They don't do it for everyone, but they do it sometimes. It's supposed to be renal protective. It may or may not actually be, but you'll see it in some textbooks. They talk about doing sodium bicarb in association with fluid resuscitation. And then they may end up on dialysis. So if their electrolytes are getting way out of whack and you can't keep them under control, if their acid-base status is really poor and you can't get it under control, which makes sense. I mean, your kidneys are your primary regulator for both of those things. And if they're not doing what they're supposed to do, then you've got to replace their absent renal function in the form of dialysis. Okay, acute interstitial nephritis. So this is usually due to medication. I think we talked about this before. So proton pump inhibitors are a main source of acute interstitial nephritis, but other etiologies can be infection or autoimmune disease. And again, it's an acute decline in renal function. Here's a whole bunch of stuff that can cause acute interstitial nephritis. As you can see, the list is long. The bottom line is removing the underlying problem usually gets acute interstitial nephritis to resolve. So you figure out what it is, and then you fix it. What do they have? They've got a fever, they've got a macupapular rash, and they've got arthralgias. They may have peripheral eosinophilia on laboratory values, and you may see white blood cell casts in their urine as well, and they may develop hematuria. This is what the skin rash looks like. It's only present in 1/3 of patients, and it typically involves the trunk. So if you classic presentation, you've got somebody who's on a proton pump inhibitor. They come in with a declining GFR, a lower BU and creatinine ratio, eosinophiliuria, then be thinking acute interstitial nephritis. Consult nephrology. Supportive measures, remove the insulting agent. And sometimes they benefit from a short course of steroids. Typically, there's good prognosis. They very, very rarely progress to end-stage renal disease. Some patients might need dialysis. Vascular AKI we've talked about. Do I need to beat this dead horse anymore? Okay, acute glomerulonephritis. Hopefully you've heard about post-infectious glomerulonephritis before, IgA nephropathy, hemic Schönlein purpura. We have a whole lecture on glomerulonephritis, so I'm not gonna beat this to death, okay? Because we're gonna talk about glomerulonephritis later. Right? Just note that these things can cause AKI. Okay. Cardiorenal syndrome, I talked about already. Any questions about that? Heart bad, damaged kidneys. Kidneys bad, now damages heart. Vicious cycle. There's 5 types. I'm not going to ask you to know what those 5 types are. Just know that AKI can cause or can arise from cardiac disease. CKD can arise from cardiac disease, etc. Hepatorenal syndrome, same thing, except liver bad, hurt kidneys. Kidneys bad, hurt liver. Vicious cycle, patient dies. Okay. Albumin improves oncotic pressure to help improve perfusion, but basically same thing as cardiorenal syndrome, just it's the liver instead. And then to make matters worse, you can have hepatorenal syndrome that then results in cardiorenal syndrome, or cardiorenal syndrome that then results in hepatorenal syndrome, and then multi-organ system failure and death. All right, kidney injury, how do you prevent it? Be aware of the patient's underlying renal status before you do anything to them, right? If somebody has chronic kidney disease, don't give them a nephrotoxic drug. If they're diabetic, manage their diabetes. If they're hypertensive, manage their hypertension. If they've got heart failure, make sure their heart failure is being appropriately managed. Make sure they're seeing the right people. Questions? All right. I know that felt like a lot towards the end, but a lot of those things, like I mentioned, the glomerulonephritis, we have a whole lecture on. We'll talk about glomerulonephritis later. Also, one quick housekeeping note: you may have noticed that if you look at the GU page in Canvas where it lists what lectures are being given on what day, that chart is actually a picture, not a graph that I can actually, or a diagram that I can actually edit. I think it's day 7. There's a lecture that's listed for tubulointerstitial disease. There is no separate lecture for that. It's built into everything else. So I don't want everybody, the last class did this. They're like, where's the slide deck for tubulointerstitial disease? Did we have that lecture? It's all built in. So don't panic about that. It's included in other slide decks. It doesn't have a separate slide deck. Questions for me? All right.